So the role of regional radiotherapy. So this is a talk about the role of regional radiotherapy. So the scope of the talk is initially we have an introduction. All right, then we need to discuss whether there's any role for no axillary radiotherapy at all. And then we talk about the regional radiotherapy trials. Currently, there are current 3 trials for regional radiotherapy. So the ERTC EMRO study, right, that talks about axillary lymph node dissection versus axillary radiotherapy. And then the MA20 studies that talks about whole breast radiotherapy versus regional radiotherapy, and then some conclusions at the end. The next slide, please. So this is a meta-analysis showing the effect of radiotherapy after mastectomy and axillary surgery. This is the early breast cancer trialist group. This was what I was alluding to earlier, and this was the 20-year data mortality presentation. Next slide. As you can see, all right, both local control and overall survival benefit, all right, has been shown in the meta-analysis for all lymph node positive patients when radiotherapy was delivered compared to no radiotherapy. This was true for patients with 1 to 3 lymph nodes, as well as patients who had 4 or more lymph nodes as well. This was regardless whether they are premenopausal or postmenopausal. Next slide. If we look at the patterns of failure, all right, in terms of the post-mastectomy radiotherapy in the 82B and 82C Danish studies, all right, you can see the most common, all right, the most common failure will be in the chest wall, right, and axillary failures and the second coming at 13% compared to 2%. Next slide. Right. So the question will be now how to best manage the axilla in patients with clinical and positive disease following sentinel lymph node surgery. So it's very clear if you have node negative after sentinel node, all right, there's no need for further radiotherapy. This has been borne in numerous clinical studies. So if you're N0, all right, there's no need for any further treatment at all. If you're N positive, right, then that's where the most of the controversy lies. If you're 4 or more lymph nodes positive, then it's very certain that you need post-mastectomy radiotherapy. However, if you are just N plus, N1 disease, then the question arises whether you need radiotherapy in the first place. So that is the question whether you need radiotherapy. So that's the Z11 study. And then whether we could substitute further surgery for with radiotherapy. So that's the EMRO study that compared lymph nodes subjected to further treatment either by radiotherapy or by surgery, that is in terms of axillary dissection. And the last one, we talk about what sort of regional radiotherapy. Is it a 3-field, a 4-field, or a 5-field radiotherapy? And whether there's any need for any axillary radiotherapy. So that is the MA20 as well as the EORTC studies. Next slide. So this is the ECOZ Z11 study. All right, this is a well-known clinical study done in Italy. All right, this is very well known with and well versed with the surgeon. So basically, this looked into the issue of a lady with early stage breast cancer, T1 and T2 clinical N0 disease, who had breast conserving treatment and then had a sentinel lymph node done, and the sentinel lymph node was positive. So this actually randomized patients to further receiving axillary lymph node dissection. So that was the test arm, and the experimental arm was no axillary lymph node dissection. And the thing to note about, because of all these patients having done breast conserving treatment, right, they all receive adjuvant radiotherapy. Next slide. So these are the clinical trial results. Now, if you look at the clinical trial results, right, the median follow-up was 6.3 years. The number of patients with node positive after axillary nodal dissection was about 27%. So this should say 1 in 4 patients were positive after the axillary lymph node dissection if they had a sentinel lymph node positive disease. Now, when we look at the results, all right, basically the results, if you give radiotherapy, all right, and you did not have any axillary lymph node dissection, as we looked at the second column, all right, basically the results was not significant as if you did somebody with the radiotherapy. Next slide. Alright. So this result suggests that no, if you have a node positive patient, right, and who's going for radiotherapy, then the radiotherapy alone will be sufficient and no need to have to do anything else. All right. So these are also very gratifying results, but also very surprising. Now the low axillary failure rates, all right, despite the 27% incidence of additional nodal metastasis in the axillary lymph node dissection arm. From the BO4 study, we know that if not all positive lymph nodes result in axillary failure. The BO4 study showed that there were 38% lymph node positive patients, but then only 18% of the patients resulted in local failure rate. Was it because the use of systemic therapy, they were using chemotherapy as well as hormonal treatment, all right? Or was it because some patients had axillary irradiation from tangential fields? Now, in this Z11 study, we know that they were not allowed to use third field, no superclef, no axillary field, just two fields tangential. So it's very important to know what kind of quality assurance that these patients did receive in terms of the radiotherapy treatment. Next slide. All right. So since the results, the surgical results in the Z11 study were not blinded, could axillary radiotherapy have been used in this sentinel lymph node patients? All right. So basically, in terms of the treatment, were it high tangents? So this is very important to know. Next slide. So what do I mean by high tangents? Okay. So this is an example of what the normal two field tangents for the non-radiation colleges in the audience are. So normally, all right, you can see the clips here in the axilla. All right, we usually put the treatment line at B where the SSN is. Now, if you have a high tangent, that might be the line you can see at marked A. So this is an example of a high tangent fuse. As you can see, a high tangent fuse actually encompasses the whole entire clips. All right. So the radiotherapy field, if you use a normally, which is B, all right, does not include the clips. All right, you can see the superior part of the clips not in the radiotherapy field. But if you extend the radiotherapy superior border to the level of A, then the entire axillary field will be treated. So this is important to know what kind of radiotherapy tangential fields was used in the Z11 study, as this may cause some biasness. Next slide. So there was a study that was published in terms of the QA analysis of the Z11 study. All right. So this was the radiation oncology that was published looking at the radiation field design in the patients receiving radiotherapy for the Z11 study. So because it has been hypothesized that the radiation oncologists could not be blinded to the patient's treatment, and basically they had the radiation oncologist who was treating the patients had access to the PEF nodes as well as the surgical nodes. They made the call on how high to put the high tension fields. So the goal of this study was to review the radiotherapy treatment records to determine if there were any significance and any differences in the radiotherapy delivery techniques and the extent of the axillary surgery. Next one. So these are examples of the tangential fields used in the Z11 study. As you can see, A, all right, slide A is a standard tangential field, so you can see it's quite low. Most of the axilla is not actually treated. Example B is an example of a high tangent. You can see almost all the axilla being treated. Example C is a third field, or what we know as in the industry as a super cleft field, SCF field. Yeah, all right, and basically C and D, we match it together with the tangent field at the end. So it's important if we look at the Z study is to see whether the axillary field is being treated or not. Is it a lot of patients having axillary type of treatment in terms of B, in terms of C and D? All right. If so, what were the results of this study? The next slide. So what are the results of the qualitative assurance, the QA study? Now, so they actually QA not all the patients. There were only about 225 patients that were QA. All right, and they actually look in the fields. All right, about 125 were on the sentinel lymph node dissection field, and basically on the other half of it were on the axillary lymph node dissection field. So we want to see what kind of fields they were. And interesting to note that 61 out of 124 patients had regional or high tension fields in the patients receiving the sentinel lymph node dissection arm. And 55 out of 104, about 50% of patients had the high tangent fields in the axillary lymph node arm. So you can fair to say that 1 in 2 patients on the trial actually had very high tangential fields or regional fields, and that may actually influence the results of why the ECOZ Z11 studies results were so good. Next study. So can we use the Z11 study results? As a radiation oncologist, right, the consensus among the radiation oncologists is that no, we can't use it. Why? Because about 50% of patients who were randomly assigned to the test arm as well as the experimental arm received a very high tangent fields. And therefore, the conclusion of these results were that no, the radiation oncologists that did the QA, right, and published the findings of the Z11 study, the safety data as well as the quality assurance panel of the radiation oncologists suggest that we should not be able to extrapolate the results of the Z11 study results to patients who do not receive adjuvant radiotherapy or those who only receive radiotherapy using partial breast or probe techniques, because a lot less of the axilla is treated as well, right? So as a radiation oncologist, when we talk about tumor board, right, when the surgeon talks about Z11 studies, whether we can actually believe the results, right, our answer usually is no, unless you can believe that because 1 in 2 of the patients actually receive auxiliary radiotherapy treatment in terms of a third field or in terms of a high tension field. Next slide. So the next study we need to know is whether we could replace, all right, further surgery or further or give auxiliary radiotherapy in a patient with N-positive disease, not especially on sentinel node positive, whether there's any further requirement in terms of surgery or further requirement in terms of radiotherapy. So to answer that question, there was the MROS study which was conducted. So next slide. So the MROS study was a radiotherapy or surgery of the axilla after a positive sentinel node in a patient with a N plus disease. Okay, next slide. So the trial design was that it was a one-to-one, previous slide. The trial design was a one-to-one, right, randomization. There were about 2,500 patients on each arm, making the total number of patients accrued about 4,800 patients. And they randomly assigned one-to-one into axillary lymph node dissection versus axillary radiotherapy in somebody who had a positive sentinel lymph node. Next slide. Right. As you can see, in this study, 90% of patients receiving systemic treatment and 82% of the patients had breast conserving treatment. Next slide. So what are the results? If we look at the results, all right, between axillary radiotherapy and further surgery in a sentinel lymph node positive lady, all right, whether we randomize to each of both, all right, there was no significant difference between the two arms. That is to say that if you have a lady with a sentinel lymph node positive, all right, if you had further surgery, they did not do any worse if you gave radiotherapy as well. So we can say that no, radiotherapy was just as good as surgery, right, in terms of treating the axilla in a patient with sentinel lymph node positive, right? So the M plus lady. So in terms of overall survival, there was also no difference. So if there were no difference in the local control as well as the overall survival, it's important that we look at the toxicity. So does toxicity make a difference? So if we look at the toxicity treatment, if we look at lymphedema, the number of years after immunization, you can see in the dark blue, the one with the surgery, the axillary lymph node dissection, compared to the light blue, which is axillary radiotherapy. All right, as you can see, as time progresses, all right, axillary lymph node dissection, the rate of lymphedema was about 40% 1 year post-treatment, and it came down to about 28% in terms of 5 years post-treatment. If you gave axillary radiotherapy 1 year post-treatment, the lymphedema rate was 21% compared to 13.6% at 5 years. So if we compare the two, in terms of axillary lymph node dissection as well as axillary radiotherapy, you can see the axillary lymph node dissection, the one in dark blue, at 5 years was 28 compared to 13.6 of the rate of axillary lymph node lymphedema in the patients who received axillary radiotherapy. Now, this is a very surprising finding because we had never expect that, no, if you give surgery, you usually expect the surgical lymphedema rate to be lower than radiotherapy. But in this study, it proved otherwise. All right. This study has shown conclusively that no, if you give radiotherapy, all right, the lymph node, the lymphedema in the arm is higher for surgery compared to radiotherapy. So this was a very surprise finding. Next one. In terms of shoulder function, right, there was no difference in the shoulder function for both radiotherapy as well as axillary lymph node in terms of radiotherapy compared to surgery as well. Next one. So in conclusion, right, the authors of the AMRA study state that no, axillary lymph node dissection and axillary radiotherapy after a patient receiving who has a positive sentinel node provided excellent and comparable axillary control for a patient with T12 primary breast cancer and no palpable lymphedema. So axillary radiotherapy also resulted in significantly less morbidity. So we can say that no, if a patient who has sentinel node positive, giving axillary radiotherapy can be the standard, right? You don't have, it can be substituted with axillary radiotherapy. A patient does not need to go for further axillary dissection. So this is a very surprising result when it first came out. So the last one when we look is the regional nodal radiotherapy, whether we give whole brain, we give whole breast radiotherapy, we give whether a two field or is it a four field, compared to a four field radiotherapy. And to answer that question, we have both the MA20 study as the EORTC studies. Next slide. So regional nodal radiotherapy in early breast cancer. So this was done by the Whelan study that was published in the New England in 2015. It actually explored the question of whether we give two fields or we give four fields or five fields out of radiotherapy. Next one. All right. Now, so this is the trial design. All right. So this trial stratified patients who have undergone breast conserving surgery plus axillary dissection as well as systemic chemotherapy, and they stratified patients in terms of 1 to 3 lymph nodes or more than 4 lymph nodes. All right. And then they randomized in terms of breast treatment alone. This is the two-field treatment, and then the test arm is four-field treatment. So in terms of the two tangential fields, a superclave field, as well as auxiliary field, and an ternary memory chain field. Next slide. So what are the results? So if we look at the local control benefit, this one, box B. All right. So if you look at the local control benefit, all right, if you give regional nodal radiotherapy and compare that just to give the whole breast radiotherapy alone, regional nodal therapy actually conferred a better local control, a better disease-free survival rate, and that was actually statistically significant. In terms of overall survival, if you look at box A, there was no difference whether you gave four-field or two-field radiotherapy treatment. Next slide. When we looked at the clinical implications of the MA20 studies, all right, because if you give four field, there'll be more lung being treated. There will also be a higher rate of lymphedema as well as the worst cosmesis. And when we compared that to the whole breast irradiation, the two field arm, all right, they were all significantly, statistically significant, all right. So because we know that if you give regional radiotherapy, there'll be more inside the field, we expect these patients to be having higher pneumonitis rates. All right, so this is to be expected. We expect the patients also to have a higher lymphedema rate, and as well as a poor cosmesis as well. So these rates of 7.3 for the lymphedema is within the tolerance of 15%, with some studies being quoted by the surgical arm, and I would say 7.3% is a very good rate. All right, it's a very low rate for lymphedema for having a 4 or 5 Q rate. Next slide. So the breast, the Whelan study, the MA20 conclusions were that for patients who are node positive or high risk node negative patients, all right, two field versus four field actually provided better local control benefit. There's no overall survival benefit at all. Okay, next slide. So this is the sister study of the MA20 study, the EORTC 22922 studies. All right. So this was done across the Atlantic in Europe. This was looking at two field versus four fields as well. Same question asked whether four field is indeed more superior than two field treatment. Next slide. Same one is to one trial design, about 5,000 patients being recruited, about 2,500 patients on each arm. Next slide. And what were the results? The results are also similar to the Williams study, all right? So both sides of the Atlantic suggest that if you have two fields versus four fields conferred a local control benefit in terms of disease-free survival that was statistically significant, but there was no overall survival and all conferred, whether you give two or four fields. So there were two conclusive, large, randomized phase 3 studies to show this result. So we can say that if you give four field, your patients had a better local control survival rate compared to somebody who received a two field as well. But the caveat is that there will be a higher side effect rate. Next slide. All right. So basically, this is the same conclusion as the MA20 study. Local control benefit, but no overall control survival benefit. Four field versus two field. So four field is actually more superior in terms of LC benefit. Next slide. So to conclude, all right, regional radiotherapy actually improves outcomes. There's no doubt about it. There's the large meta-analysis. There's the Williams study. There's the EORT studies. All right, the Portman study. So basically, regional radiotherapy is the way to go in N-positive patients. All right, there's some toxicity as a trade-off in terms of higher lymphedema rates. All right, in terms of selection of patients, we need to work out who benefits the most. Certainly, if in N positive patients or sentinel positive patients, whether further surgery is beneficial or can we just substitute by radiotherapy alone. The MROS study actually shows that the radiotherapy is just as good with lower side effect rates. And what kind of treatment techniques? I would say the four fuse treatment techniques is more superior in terms of conferring a local control benefit. And if you want to do it, you need to do it safely. So we need to talk about the different types of radiotherapy technique, whether you use IMRT, you use breath hold, you use other sorts of techniques. So that's in a further talk. And basically, lastly, next slide. All right. So I'd like to thank the organizers of the Oncology Club for inviting me to give the talk. And this is Singapore. If you'd like to come and visit, thanks very much.